Good afternoon, everybody. It is my pleasure to invite you all for this academic event stipend session on acute coronary syndromes. And the speaker today is Dr. Pratheema Ramachandran. It's my pleasure to introduce her. Dr. Pratheema is a very enterprising academic and a wonderful teacher. She's a lead intensivist and a senior consultant intensivist with Apollo Hospital. And I hand over without any much delay. I hand over the session to Dr. Pratheema to speak on acute coronary syndromes. If you have any doubts, you may record the questions and we will address them at the end of the session. Over to you, Dr. Pratheema.
Thank you, Dr. Kalavathy, ma'am. Very nice to meet all of you online. Yeah. I know it is dangerous in a post-lunch session, but I'll try and keep it as interesting and interactive as possible. So today's topic is acute coronary syndrome. So this is like every one of us, doctors and nurses in ICU, it might be at least daily. We used to see people admitted in ICU or people getting admitted into ICU with diagnosis of acute coronary syndrome. So I think it is a very, very important topic. So we will just have a good overview. And if there are any doubts, we are happy to take it. Please enter it in the chat box and we will discuss at the end of the class. Or even if you want to unmute and you want to ask any question then and there also, it is fine. So I'll just start the topic. Acute coronary syndrome. It is also, we call it...
sorry to interrupt you, ma'am. But ma'am, please on your camera. While session, you have to on your camera.
In this tab, the camera is not possible. Once I stop screen sharing, no, I'll come back.
Okay. So, okay.
This is a technical thing. So, fine. Sorry about the technical glitch. So,
okay.
Just a brief interruption. Dr. Pratheema, Aparna Vani has lifted her hand. We will address any doubts at the end of the session. So, over to you, Dr. Pratheema.
Okay. Thank you, ma'am. Yes, as ma'am said, we will do it at the end of the session. So this is about acute coronary syndrome. We call it as a heart attack. We call it myocardial infarction. There are a lot of terms, infarction, ischemia. We'll just have to split it and get a very good, clear overview about what are we talking about and what is the definition, what is the pathology, types of MI and how to diagnose and what is our role in ICU. So if there is a patient with acute coronary syndrome, what is our approach? So just to bring it into a very, very simple definition is that if there is any evidence of myocardial injury, so there is a myocardium, you know that it is a muscle of the heart. If it is going for any injury with necrosis in a clinical setting consistent with myocardial ischemia. So to say it in English, not to use very medical terms, it is like the heart is suffering with loss of blood supply or low blood supply causing a cellular injury. And in turn, the muscle is slowly dying or the muscle cells are slowly dying and going for a necrosis. So what happens is one side the oxygen supply is there and one side there is an oxygen demand. If the demand is very high and the oxygen supply is not able to match, then there is a disparity and the heart muscle goes for a ischemia. So how it occurs? So pathophysiology, as I have put in the picture here, it is showing a vessel. As we know, there are coronary arteries, and if there is a block of the coronary artery, it is called a myocardial infarction. So how this block happens? So inside the blood vessels, there are 3 layers, and the interior layer is called the endothelium. So endothelium, under the endothelium, if there is going to be a lot of fat lipid deposits, slowly it is going to swell up and narrow the vessel, causing something called a plaque. So the plaque will be narrowing the lumen of the vessel. So when there is turbulent blood flow and in case the cap ruptures, cap of the fibrous cap of the plaque ruptures, the blood thinks that it is the injury which is happening outside. So it just forms a clot because anywhere there is an injury, our body has mechanisms to form a clot, whether it is outside or inside. So when this happens and already the lumen is very small and there is a big clot, the platelets go there and they just sit over the cap and make sure that it is covered. One. Then after that, there will be a formation of the fibrin over that, fibrin deposition over the platelet clumping. So that causes a big blood clot, which blocks the artery. So as you can see that the dead heart tissues at the site of blockage, it is like slowly discolored and it starts dying. So this is what I have told you. The 3 layers of the vessel is intima, media, and adventitia. So intima is the innermost and endotheliumatus. So the lumen is there. You can see that slowly the plaque starts developing. And when the plaque is at least half lumen is covered or blocked, sometimes when the patient walks or the exerts, there should be an increase in supply to the heart, which doesn't happen because the lumen is narrow. That time the patient gets a chest pain. So that is called a stable angina. This is not a emergency situation. Stable angina is there only when the patient exerts and adequate blood flow is not there to the heart muscle. But when there is a rupture, then it is coming under an acute coronary syndrome. So acute coronary syndrome, there are 3 types. One is unstable angina, other is the non-ST elevation MI, and other one is the STEMI, we call it, ST segment elevation MI. So as you can see in the picture, unstable angina has only the cap and blood clot is starting to form. There will be ischemia. Definitely, there will be very, very low flow to the heart muscles across this fibrous cap in the vessel. In non-ST elevation, half of it is blocked, almost complete block. But when it is fully blocked, it gives rise to ST elevation MI. So of the 3, the most emergent is to correct the ST elevation MI. So STEMI is very, very important. It is a very, very emergent situation where you have to open the artery or open the vessel to create the flow. So it is called the revascularization. So that is the STEMI. And NSTEMI is also equally important because NSTEMI can become a STEMI sooner or later. So we have to be very, very careful about the patient's symptoms and how we are going to approach about it. So there are many types. So MI, we just call it MI and just leave it. But there are almost 5 types, basically 6 types. But as per theory, there are type 1, 2, 3, 4A, 4B, and 5. So type 1 is what I mentioned till now. It is a spontaneous MI. Just that the fibrous cap ruptures and there is a big clot formed which occludes the artery. That is type 1, spontaneous MI. Type 2 is MI which occurs due to ischemic imbalance. So when the patient exerts or when the patient is in sepsis, already the patient is having a coronary artery disease, it worsens leading to a MI. So this is type 2 MI. Type 3 is when suddenly there is a cardiac death without any biomarkers. The troponin or anything else will not be positive, but suddenly there is a MI and which leads to sudden cardiac death. So type 4A and 4B are nearly equal. So when there is a PCI going on, I will discuss about PCI, what PCI is and what is that procedure when I go further into our session. So when that happens, when MI happens during a PCI, it is called 4A. And if the stent which is placed gets thrombosed, that is 4B. And type 5 MI is related to CABG. Post CABG, if the grafts get blocked and MI happens, it is type 5. So it is just for the theory. So management is very, very important. We must know the pathology. So common initial presentation. Patients come in with, whether it is unstable angina or NSTEMI or STEMI, patient comes with chest pain, sweating, non-specific referred pains, jaw pain, can be anywhere. It will be a very non-specific pain. Continuous patient will feel unwell and they will feel even just giddiness or vomiting. So initial treatment is also common and we must know the related pathophysiology. And it is sometimes it is difficult to diagnose with lot of differential diagnosis. We will go into one by one. So clinical presentation, for diagnosis, it is very, very essential is clinical presentation, ECG, biomarkers, and echocardiogram. So of these, the most important is the clinical presentation. Then comes the ECG, then comes the biomarker and the echocardiogram. So the patient comes with a chest pain, which is central crushing. It can be having referred pain to the shoulder, upper abdomen, and jaw. The patient might have sweating, vomiting, giddiness, palpitation. So anything which like makes the patient unwell. And there can be hypotension. Because of that, the patient might have giddiness, or arrhythmia, the patient might have giddiness. So clinical presentation is very, very important. Even though the ECG might be normal, or it might appear normal during the initial stages of MI, we just have to keep the patient in the emergency room, observe, and just do repeated ECGs or take a immediate cardiology opinion if we feel that the patient is having continuous symptoms or a persistent symptoms. So there can be a lot of differential diagnosis. Similar type of pain can present in aortic dissection, pulmonary embolism, pleuritic chest pain. Pleuritic chest pain happens when there is an inflammation of the pleura, and every time the patient takes in deep breath, there will be a pricking pain, and sometimes a peptic ulcer and polylithiasis. So coming to the ECG, what are the changes? So STEMI, we know ST elevation. So there will be an ST elevation in 2 contiguous leads, and there are voltage differences which we can see in men and women. This is just for theory, but you have to make sure that you can identify a ECG which shows a STEMI. So there can be a new left bundle branch block. So if it is a N-STEMI, there will be ST depression. So non-ST elevation MI in T-wave inversion or ST depression can happen in unstable angina or N-STEMI. So this is what happens in a ECG. As you can see, this is I have depicted the various waves, and here the ST segment is clearly marked. And when the normal ECG, the ST segment will be with the baseline or a little above it. And when there is an STEMI, we can see that above the baseline it is coving, or it is just getting elevated in a STEMI. And non-STEMI, we can see that the T wave is inverted and there is an ST depression. So these are the features which can be seen in the ECG, so that we can identify or suspect a MI. So ECG. So ECG is electrocardiogram. It is mapping of the heart. And we know that there are 3 blood vessels, very, very important, or left anterior descending and left circumflex, which forms from the left main coronary. So there are 2 coronaries, right and left. So right coronary artery just comes down, supplies the right side of the heart. Left coronary artery divides into 2, which is the circumflex and the LAD. We call it LAD LCX. So this is a lead summary. So where do we have to look in the ECG for which vessel? This is like it's not a very accurate, it is approximate. So when you look at the lead and see that there is a 1 AVL and V5, V6, we know that the lateral part of the heart is affected. And when there is 2, 3 and AVF is affected, is inferior part. So each part of the ECG or each lead of the ECG shows different sides of the heart. And we can just approximately just decide or diagnose which artery or which blood vessel is affected. So this is anterolateral MI. So anterolateral MI, as I said, we have 1 AVL and V5, V6 involvement. We can see that it is spreading to V3, V4 also. So anterolateral, this is not only lateral, the anterior part is also affected. So inferior wall, 2, 3 AVF. As I mentioned, we can see that there is a ST elevation in second lead, third lead, and AVF. So if it is like only in the second lead, no, not in third or AVF, then it might be an artifact. So if the patient is not having any symptoms, we can repeat it again or take an opinion from a cardiologist also. So this is posterior wall. So when the posterior part is affected, there can be deceiving changes. Here we can see that there is a ST depression. But because it is happening in the posterior wall, all these leads show inverted ST elevation. So when we invert this ECG, we can see that there is an ST elevation, or we can do something called the posterior leads, posterior chest leads. If we can keep the ECG inverted on the posterior or back, on the back of the patient, we can see that there is an ST elevation MI. So that is with the clinical presentation, and we saw the ECG. Now we have come to the biomarkers. So biomarkers. So these are markers. So what are these? Actually, when there are substances which has to be present normally inside a cell is found in the blood, then that means that the cell has got some injury, or the cell is broken down and release these enzymes outside. So basically, there are many enzymes inside the myocardial cell, particularly troponin. So troponin is there, something called the creatine kinase is there. So creatine kinase, CKMB, is a form where it is present in the myocardium. Plain CK is found in all the muscles. So it is a enzyme which is found inside the cell, and when the cell has an injury or it gets lysed or necrosed, all these enzymes come into the blood. That is why we use these biomarkers to find out whether there is a cell injury. So for the heart, we have this graph. So this is like days after onset of an acute MI. So once the MI starts, in few hours, the troponin will start rising. Initial troponin might be negative, and after 6 hours, sometimes we repeat and see whether the trend is going up or it is positive after some time. Then that means that troponin has come into the blood. That means that there is an MI. So troponin, this biomarker is very specific for, it's more specific for the myocardium. One. Second is, this troponin will start slowly, and it will take a long time to clear from the blood. So in case the patient has a second MI on the second or third day, then it is better to do a CKMB, because it starts late, but it goes off very early, maybe in 2 days. So if the patient has a new MI or a repeat MI, we can always do CKMB, which is more specific for a repeat MI within a short period after the first MI. So these myocardial infarction biomarkers are helpful in diagnosis. But troponin can be positive in sepsis. Troponin can be positive or elevated in renal injury or acute kidney injury or any muscle necrosis. So we have to be very, very careful, and we have to think twice about taking the value or interpreting troponin. So acute coronary syndrome, I have already told. So again, coming to the subject. So ST elevation MI, cardiac marker will be positive. And in non-ST elevation MI, cardiac marker is positive, but with ECG changes. But in unstable angina, cardiac marker might be negative because the cell has not yet started getting injured or broken down. So there is definitely signs of ischemia. There is a T-wave inversion in the ECG, but the cell has not started having any major ischemia. So that is why cardiac marker is negative in unstable angina. But soon or later, unstable angina, if not treated, can become an NSTEMI or a STEMI. So we have to be always careful in taking care of these patients and always monitoring them. If there is ongoing chest pain, it is always better to rule out MI, take a cardiology opinion, and give them the necessary medications, which we will be discussing in a short while. So, as I said, clinical history, ECG changes, if it is yes, STEMI. If there is ST elevation, yes. If there is not much of ECG changes, then C for a troponin. If it is yes, then NSTEMI. If it is not, if there are ECG changes but no elevated troponin, then it can be unstable angina. So echocardiogram is the last part. I did mention for the diagnosis, we need clinical presentation and ECG, biomarkers, and the echocardiogram. So echocardiogram has various windows in which various parts of and various views of the heart is seen. And if the movement is a problem, the contraction is a problem, if there is any thinning out of the ventricle or thickening of the ventricle, we can definitely see and find out. There can be regional wall motion abnormalities, which is very, very specific for a MI. That should be new. And in case a previous or a recent previously done echocardiogram is available for the particular patient, we can always compare. So how do we treat? So this is the overall view. I'll just tell this flow chart and break it into pieces, and we will be discussing one by one. So initial treatment, if it is STEMI or NSTEMI, we just go and give them antiplatelets, anti-ischemics, first analgesia, then anticoagulant therapy. For both, it is the same. But for STEMI, what we do is we make sure that we break the clot. So we give some thrombolytics, or we just send the patient, if the cath lab is available, immediately for a PCI. Okay, if there is a very less success of PCI, or it is going to be very high risk PCI, there can be an option of CABG given under emergency basis. So if it is NSTEMI, then they can do an angio later. In case there is a clot which is starting to form in, they can always put in a stent. That is called a PCI, percutaneous intervention. So management, what do we do? Pharmacotherapy. So medically we treat, there are procedures to treat. So medically we give antiplatelets, fibrinolytics and anticoagulants. For STEMI, we can give revascularization, like revascularization, as I said, maintaining the patency of the lumen, breaking the clot. So it is by fibrinolysis. We give some drugs to break the clot, or we just send the patient to the cath lab where a percutaneous coronary intervention is done, where a wire is passed through the blocked vessel and a stent is placed. So what are antiplatelets? So when I talked about the fibrous cap and formation of the clot, I did mention that platelets first go and sit there and try and block the further bleeding or the gap which was formed by the plaque rupture. So that is called a white clot. Platelet aggregation is the first thing which happens when the clot starts to form. So that is called a white clot. So we have to first start with antiplatelets. So what are the different antiplatelets? We use aspirin, clopidogrel, prasugrel. And there are also intravenous antiplatelet therapy, which we give even post PCI or post stenting. We give this as a IV infusion. Most commonly used is tirofiban, and all these doses and how you have to give it at what time is all the institution protocol. So this is a very common protocol. It might not be fitting into an institution, but this is what are the guidelines. So initial dose of 325 milligram of non-enteric formulation. So it is not a coated aspirin first we give. It is aspirin which is non-enteric coated so that it starts working fast. So that is first given. Then clopidogrel loading dose 300 to 600 milligram followed by 75 milligram per day. So it is either clopidogrel or prasugrel or ticagrelol. Nowadays there is ticagrelol given. So that is 180 as a bolus or a loading dose, followed by 90 milligram twice a day or once a day. So that is how in different doses it is being given. I don't want to mention the company names, but you just have to know about the basic molecule and how much dose we are giving. So then when after the white clot forms, then the fibrin strands go and sit and cover over the white clot. Then the clot becomes red. So this red clot is addressed by the anticoagulants. So anticoagulants, we use heparin, we use enoxaparin, fondaparinux, and sometimes when there is a heparin contraindication, we use bivalirudin. So very commonly used is heparin and enoxaparin. So along with the doses I have mentioned here. So we need to know that why we are giving antiplatelets and why we are giving anticoagulants. So antiplatelets and anticoagulants have different modes of action. And fibrinolytics. So this is breaking the clot. So clot is formed. How do we break it? First is to address.
Pratheema, may I interrupt? There is a request if it can be partially in Hindi. Is it possible?
I'm not fluent with the Hindi. I'm sorry.
Yeah, fine. Okay. If there is any possibility or in between to interject, maybe you try. I leave it to you. Sorry for the interruption.
Totally fine. Totally fine. So I'm sorry. I'm not fluent in Hindi. I'm better with English. So I'll repeat if at all you need some clarification at the end of the class. Wherever you want to discuss, we can discuss. So yes, one is forming of the white clot. Then we address the red clot. And now if the clot is formed already, we need to break it off. So streptokinase, altiplase, reteplase, tenecteplase, you would have heard about all these medications. Streptokinase is not used nowadays. It is an age-old drug, but yes, it is still used, but not very commonly. Nowadays, the most commonly used is tenecteplase. So it has a very ease of bolus dose. It doesn't need any infusion, any monitoring at the coagulation site. It just one dose of IV as per the weight. So 30 milligram, if the patient is a 60 kg, lesser than 60 kg, 30 milligram. If it is 60 to 70 kg, 35 milligram. So it is a very clearly just mentioned in the drug labeling also. So it is very easy to give. It is a one-time dose of IV bolus. So fibrinolysis, it is very, very important to do less than 2 hours, because whenever the clot is formed, the muscle starts dying, cells starts going for necrosis. So if less than 2 hours, we are able to fibrinolyze a patient, less than 2 hours of symptoms start. So it is the best outcome. Patient will have a very good recovery and should be done within 12 hours. If the patient has crossed more than 12 hours, there is no use for doing a fibrinolysis, because the clot will be stabilized, and the success of fibrinolysis or breaking the clot is very low. So PCI is a percutaneous coronary intervention. It is preferred than the fibrinolysis. If we have a cath lab in our institution, it is better to always not thrombolize and prefer PCI. If the PCI center is away, if it is only 2 hours, then it is more than 2 hours away, then we have to thrombolize the patient, then transfer. So when they reach there, they can just reevaluate the symptoms, which is called a regular PCI. So they will see the ECG. If it is not settled, they will do a PCI, which is called a rescue PCI. So regular PCI is done after thrombolysis, even if the symptoms have settled, to reevaluate the blood flow to the heart. If the ECG, if the fibrinolysis is not successful, we can do something called a rescue PCI to re-establish flow to the heart. So this is what I have been explaining. So immediately, if the patient has a chest pain, the emergency medical service, like we have to alert the ambulance. The patient has to reach the hospital soon. And once after the patient reaches the hospital, ECG within 5 minutes, diagnosis should be within 10 minutes. And immediately to the cath lab, patient has to be sent to the cath lab. If it is a cath lab center, then primary PCI has to be done and the wire has to be passed within 1 hour. If it is away, more than 120 minutes away, if the PCI center, your hospital doesn't have a cath lab and you want to send the patient to a nearest cath lab is more than 2 hours ride, then you have to thrombolize, then send the patient. So that is what is the guideline. So what next? So we have seen the patient has come. We have diagnosed STEMI or whatever myocardial ischemia is there. The patient has gone to the cath lab, finished the PCI, fibrinolysis was done, everything is over. Now the patient has come to the CCU. So patient comes to CCU post PCI, needs to be monitored at least for 24 hours. Why 24 hours? Because after the block is removed or the flow is re-established, there was already some ischemia to the cells, so they will all be angry. There will be a lot of inflammatory mediators, there will be cardiac irritation, there can be a lot of arrhythmias. So what is our role? So as usual, our role is A, B, C, D, E. So A, B is airway and breathing, C is circulation, D is looking at the disability, GCS, E is exposure, so fever, any bruising, hematoma, pain, everything. So airway and breathing. So what do we look into in airway and breathing? So is there a need for mechanical ventilation? If the patient is having ongoing ischemia, if the patient is not settled, if the stent placement is not successful, and there is a lot of pulmonary edema, the patient is becoming hypoxemic, then we do intubation. We do not put an NIV for a patient who is having ongoing ischemia or active symptoms. Okay, so be very, very careful. We are not going to put the patient on NIV for if the patient is having an MI. If the patient has pulmonary edema or because of severe LV dysfunction, pre-existing cardiac failure picture, NIV is indicated, but not in a patient who is having severe symptoms of chest pain and ongoing ischemia. And oxygen can be given only if the SpO2 is less than 90. So airway and breathing, we have to be very, very clear. So in the circulation part, we take care of the monitoring the BP, heart rate, ECG. So we have to watch out for arrhythmias. So if there can be a bradyarrhythmia, tachyarrhythmia, sudden drop in blood pressure, ECG can show ischemic changes. We have to make sure we do the echo. So is it a LV or a RV, left ventricle or a right ventricle dysfunction? Is there any clot inside the ventricle? I'm not talking about the clot in the artery. I am talking about the clot inside the ventricle. Sometimes it might happen. So next is readdress analgesia. Always make sure patient is comfortable. The pain should be always taken care of. Yes, we have to look into the look into relieving the block in the heart vessels, but the patient should be comfortable. So opiates, always we try and give them a little bit of fentanyl and morphine as per institutional protocol, as per the clinician dictates. That's why I'm not talking about any doses here. So next is glycemic control. It is very, very important that when the patient is post stenting patient, the patient has to have a very good control of the sugar. 140 to 180 is very, very important. And we use only short-acting insulin because the patient might have some vomiting, not good intake. So it's better to avoid hypoglycemia, and oral anti-diabetic drugs are not avoided, are not given and avoided for the first 3 days post-PCI. But nowadays, after 1 day, the patient is comfortable taking good meals, is not having any other gastric issues. We do give them oral anti-diabetic drug, but it is on an individual basis. So always look out for bleeding. There can be hematoma at the site of access. Post thrombolysis, there can be a GA bleed, gum bleed, because we are giving a clot buster. We call it like which breaks the clot. It can cause bleeding of the gastrointestinal tract, of any ulcers, pre-existing ulcers. There can be a gum bleed. So always be very, very careful and monitor the peripheral pulses, because in the femoral region or radial region, they might have put in a sheath to insert the wires for the cath purpose or for placing the stent, and there can be ischemia in the lower and the upper limb. So we have to be very, very careful. And hydration is very, very important. It's not like the patient is in cardiac failure, you should not give them any fluids. Allowed, as allowed, you have to always assess the volume status, then you can give normal saline as permitted. Discuss with your team, discuss with your doctor, and whatever is allowed, it is important that you hydrate the patient. And electrolyte should be monitored, lactate and renal function should be monitored, because in cath lab we use and during the procedure we use contrast. It might hit the kidneys, cause renal failure. There can be cardiac failure. Slowly increase in lactate will show that the patient is not doing well. Electrolytes, particularly potassium, if the potassium is low, it can lead to more arrhythmias, and the patient can go for serious situations like sudden cardiac arrest or arrhythmias, which is fatal. And other drugs which we can consider is beta blockers and statins. We usually give it as a cholesterol lowering drug, as well as it causes anti-inflammatory thing. We also start with the within the 24 hours of MI, if we start AC inhibitors, it helps the heart to remodel and the heart recovers soon. That is what the guideline says. So what are the complications? What can we expect post-MI? The patient can go for a cardiac failure, cardiogenic shock. In those situations, either we start with NIV and put them on a mechanical ventilation. We diurese them so that the pulmonary edema is not there. Sometimes if the stent is blocked, the patient is returned to the cath lab, where repeat angio, check angio is done to see whether the stent is blocked or not. IABP insertion is very important. Sometimes to help the heart have a good blood supply, we can just for a temporary purpose till the heart recovers, we can help them with the IABP, intra-aortic balloon pulsation, balloon pump insertion, and vasopressors and inotropes are given to support the BP till the heart recovers. So arrhythmias, as you can see in the ECG in the top part of the screen, there is atrial fibrillation. Rate control is very, very important, because if the heart beats very fast, already the heart has suffered injury, and heart has low blood supply, just now recovered. If there is a big atrial fibrillation and if the demand is so much, the heart will start failing. So we have to be very, very careful. If there is extensive muscle damage, then we have to use amiodarone, digoxin will be helpful. If the LV function is good, then we can try and use beta blockers. So there are some arrhythmias which are benign. That means that it is expected post stenting of the patient or post fibrinolysis. This is what I have shown as idioventricular rhythm in the lower part of the screen. So that is a very common ECG, or you can see the rhythm. We don't need to worry much. It might be The patient might be asymptomatic and the vitals are good. You don't need to worry about it. There can be bradycardia. So there are two types of heart blocks. If the patient has an inferior wall MI and there is a heart block, then if they put in a stent or if the clot is broken and the vessel gets the blood supply back again, then the heart block will resolve. But in case of anterior wall MI, if there is a heart block, then the patient will require pacemaker implantation. So these are the two types, because the right side coronary artery supplies the SA node, and if the artery is blocked, then it is an inferior wall MI, and the blood supply does not reach the sinoatrial node that causes the heart block. So once we establish the blood supply again, it will be totally rectified and the patient might not need a pacemaker. But in anterior wall MI, if a heart block occurs, then the patient might need a pacemaker implantation. So mechanical complication, because of the low blood supply, there can be muscle rupture, free wall rupture. These all are very deadly. The patient might, we might lose the patient. Sometimes if it is very, what to say, if there are cardiothoracic people around, and if we catch it very early, then these patients can undergo surgery. They can be put on cardiopulmonary bypass pump. Then the ventricle can be repaired. But these are very, very dangerous, and the mortality risk is very high. So myocardial stenting, LV clot, and this clot can happen because of the thinning of the ventricular wall, and because the wall is thin and there is stagnation of blood, the pumping is very low, the blood forms a clot. And sometimes when the heart contracts, this clot can embolize and go to the brain, causing stroke. So these are all the mechanical complications which can occur after a heart attack. So this is one last slide. So we need to know about myocardial ischemia with no occlusion of coronary arteries. So this can happen even without any occlusion. This can happen. So this can happen when there is a stenosis of coronary stenosis, and if it happens, we just have to do an angio. And other diagnosis can be, this can happen because of myocarditis or any very small vessel in coronary artery getting blocked. We can see that there can be a myocardial disease, so pulmonary embolism. So when I said, as I previously mentioned, the type 2 MI. So in these, we don't need to really place a stent. We just have to do an angio and exclude whether there is an obstruction or not. And we can treat as per the guidelines. And we can take a cardiology opinion and take their expert opinion and go according to that. Thank you. So if there are any questions, I'm happy to take it.
Thank you, Dr. Pratheema, for the very comprehensive and complete, and yet the topic was made simple and very clear. Thank you. If the participants have any questions, you may please type in the chat box, and we will try to clarify the questions. Some of you were raising hands during the session. We were not able to interrupt the session. So I had we had initially told that at the end we will take questions. If you have any doubts, please type in the chat box. We will address. Yes. There's a hand raised. Yes, Ms. Shalu. You can type in the chat box or you can ask the question. Yeah, there is one question. If ST elevations after 10 days and patient is asymptomatic, then what do we do?
So
if ST elevation after 10 days and patient is asymptomatic, then what do we do?
So
that is the question.
Whether the ST elevation is in the same leads or in the other leads also. One always check whether the ECG is valid. If the patient is asymptomatic, then we can look at the troponin, then an echocardiogram. But usually when there is not much pain, the patient might not have an MI, but we always have to because once he has a MI, he is at a risk of getting one more again. So always it can be done, it can be checked through troponin. If it is more than 10 days, we can repeat the troponin and see the serial levels. And we can do the echocardiogram and see whether there is a change in the pumping or any new onset of region wall motion abnormality. So all these things can help us to see whether there is an MI. Sometimes what happens is patient goes for pericarditis, where myocarditis or pericarditis will show ST elevation. So only ST elevation will not prove that the patient has a MI. So each has very different ways of presentation. Ma'am, you want to add something? Is that okay?
No, but Pratheema. And go for an angio.
Sorry, I can hear you.
Plan angio. Any
Yes.
other questions?
Okay, ma'am. Thank you.
Dr. Parihar, you raise your hand. Please unmute and speak.
Yeah, thank you.
So any questions, any doubts where you just felt you wouldn't understand anything, you can always ask, and I'm happy to repeat it. So feel free. It's not an exam. It is just a discussion.
Yeah. Yes, you can please type the questions in the chat box. It makes it very easy. Any more questions or doubts? And some of you had difficulty with the language. If you haven't understood it.
Ma'am, you are muted. We can't hear.
Am I muted?
Now we can get the voice back. Yeah. How do you treat ST elevation?
Yeah.
So that was the entire class about. So ST elevation MI is the block of the entire artery. And if there is a block of the entire artery, we need to open it. So as I said already, it is antiplatelets, anticoagulants, and immediately the patient has to go for cath lab for a PCI check angio.
There is another question. Patient comes to emergency with chest pain and there are no changes in the ECG. Then how do we address this situation?
Okay, even the echo is normal or ECG is normal. If the patient continues to have pain, first it's better to do a troponin. That is very important. If it is normal, wait for 6 hours and do a repeat troponin. And meanwhile, after an hour, ECG will be taken and the serial ECGs has to be taken. And we have to think about the differential diagnosis of pleuritic chest pain, peptic ulcer. So it is not very difficult to give antacid to the patient. So just give an antacid. If it is peptic ulcer, it will settle. Do a chest X-ray. You will know whether there is a patch, pneumonia. You can do a CPC in the meantime of observing the patient in the emergency ward. So definitely, if the patient is having a chest pain, enzymes need not be normal. If they are normal, then we have to do serial enzymes. Maybe when the patient is presenting very early, then there are chances that the enzymes are normal. So definitely after 6 hours, we need to repeat. If the patient is having ongoing pain, better to admit and observe. Please do not discharge the patient just giving an antacid. So if it is not proven otherwise, it is always better to keep the patient in the hospital till we do repeated troponin and take a cardiologist opinion. Of course, we have experts. It's better to refer to a cardiologist if there are cardiologists not available in the hospital.
Yeah. So that we have to make note, never dismiss the patient's symptoms until we are 100% sure that it is not cardiac. Never send the patient with a pan or with a gelusil or with any mucane gel. Never assume that it is a gastritis pain. Sometimes even the patient says that it is gas, and because of that there is pain. But we can never go by that. Always we need to make sure that because many times the diagnosis of MI has been missed when the patient has come with vague symptoms or even with the chest pain. And initially ECG has not been showing any changes, and the treating doctor has sent them away saying that it is nothing or it is just gastritis. Later, we had one patient who came back with the progressive MI, and then he had arrested, and then he developed hypoxic encephalopathy. Like that, this is not just one instance, but there have been incidences where patients have been sent back home telling it is nothing. So we have to be very careful before declaring the patient as having a non-cardiac issue. So there is another, whether there is a need to treat ischemic hepatitis.
So as he has already mentioned, he or she has already mentioned.
But there is an increased SGOT, SGPT.
Yeah. So when it is ischemic hepatitis, the transaminases or SGOTPT will be more than 1,000. It will be like very, very high. I have seen till 12,000. So this happens when there is a severe congestion, and particularly in right ventricular heart failure. So these patients, if we relieve the congestion, if the heart starts pumping better, and if the perfusions stabilizes, slowly the patient's liver function tests come back to normal one. And usually when there is a necrosis, we always give them N-acetylcysteine therapy. So that it is, I don't know whether it will work for the liver, but for our own satisfaction, we give that. But unless the heart pumps and the congestion is relieved and blood supplies perfusion is maintained in the liver, this will not settle. It is definitely, we have to treat it, but we don't have to treat it separately. As you said, because of ischemia. So if you correct the ischemia, hepatitis will get corrected.
Yes. So basically it is again revascularization and established perfusion. There is another question. What is the normal range for ST elevation?
There is no normal range. ST elevation can be at very different or very, very subtle levels also. Like it is how we pick it up. If it is like a very big elevation, then that means that it is an hyperacute MI. The block is very severe and immediately the patient has to go. There is nothing like normal elevation. So it is like you have to see whether there is a patient's symptom, even if there is no ST elevation, if the patient is very, very symptomatic with arrhythmias, we have seen patients who present with ventricular fibrillation. There won't be ST elevation, but the patient comes in with a syncope and ventricular fibrillation, that is MI definitely. So there is nothing called there is nothing like it is a normal ST elevation.
And we have to see the trend also. It is not just one reading, but that is why we are asked to repeat after 6 hours so that we will know the trend from the baseline. When the patient presents, we take a troponin and then go for the next one. So even if it is negative in the first reading, the next one after 6 hours will show if there is any myocardial injury. So it is also the trend and the as Pratheema said, to what extent it has increased. That shows the extent of myocardial injury also. So there is another question. Patient comes with severe chest pain and then without biomarkers, can they go for angio?
Yeah, it can be done.
Patient comes with chest pain and without any biomarkers, can they go for angio?
So that means that we have already taken a cardiology opinion. Cardiologist has seen the patient, and the patient will be getting an echo also. Even the echo is normal. Angio can be done if the symptoms are very specific and it is having a cardiac sounding pain. So the patient's cardiac pain will be definitely different. And if we have the cardiologist saying that we have to rule out cardiac ischemia, we can go ahead. There are instances where we have done an angio and it might be normal also. But that is at least good that we get relieved and we can rule out myocardial ischemia and treat other causes. Many times the instances have happened, as you have rightly asked, the patient will come with severe chest pain. Troponin might be not available in the situation, or it is taking late. The patient is having severe chest pain. The patient is rushed to the cath lab and angio is done, and it can be just a normal angio. So this has happened, but it is always better to rule out ischemia and treat other causes. So angio is just one more investigation or imaging. It's not like they are going to place a stent. So if it is there is a requirement for an angio, better to get it done.
So as Mr. Hemendra Parmar also said, one non-invasive investigation which is helpful is echo. Echo will show if there is any regional wall motion abnormality. There is another question. Yeah. What to do with a patient with acute MI with low economic strength and active GI bleed? I don't know what you mean by economic strength, but
Yes.
what to do with a patient with acute MI and active GI bleed?
So when there is a bleed and a clot, we always look at the bleed, because when we have to give more anticoagulation, then the patient is going to bleed more. So it is better to maintain the perfusion and see whether there is a place where any intervention is going to stop the bleeding, or can we do anything to find out whether the bleeding is short-lived. We can sometimes increase the hemoglobin, give a good perfusion, and we cannot be giving antiplatelets or anticoagulants for a patient who has active bleeding going on. So that is the guideline. One. Second thing is affordability. It is always better to thrombolize, or I think thrombolysis is also costly, but life is more costlier. We can actually refer to a government setup where the thrombolysis might not be so costly. But in case if it is a very short time, we can always thrombolize. We can talk to the patient and see whether they are okay, and we have to thrombolize. If the patient gives consent, we have to go ahead. Because the patient is poor, we cannot decide not to thrombolize. It is the consent. We have to explain everything, take a consent, and thrombolize.
Yeah. There's another question. ST elevation of more than 1 millimeter in 2 contiguous leads with new onset LBB.
Yes, that is I think they have given the definition because somebody asked how much is the ST elevation. So just for theory, it is there, but I will not advise this, because even without a ST elevation or with a major ST elevation, it doesn't make a difference if the patient is having a very severe chest pain. So we don't wait whether there is going to be more than 1 millimeter or it is not. We have to consider as a coronary ischemia whenever the patient has severe pain and troponin is elevated.
So would you call it a STEMI is the question?
Yes. I always go with clinical presentation, and the STEMI or NSTEMI, it doesn't matter even when the patient has ongoing chest pain. I will ask the cardiologist to have a look and take the patient to cath lab as soon as possible. Definitely, if there is no bleeding or any other contraindication, I will load with antiplatelets and send to cath lab.
Would you then call it as an NSTEMI?
See, I'm again and again saying STEMI and NSTEMI, it is all theoretical. When you stand before a relative, you imagine that patient is your friend or a relative, you won't be naming it as STEMI or NSTEMI. You want the patient to live, and you have to do everything in our possible effect to make the heart have a very good blood supply. So always do not go by definition, which is theoretical. This is approach to acute coronary syndrome. So acute coronary syndrome, anything can happen anytime. There can be sudden arrhythmias. So heart has to get a good blood supply from all the 3 vessels it has. So I will be looking into whether it is a STEMI or NSTEMI. Name doesn't matter. If it is a ischemia, it is a ischemia. If it is a full block, it is a full block. So if it has to be relieved, it has to be relieved. So that is how I will be looking at it. Because we are intensive care people, ICU people. So, patient sitting and eating suddenly has a ventricular fibrillation. We will not be sitting and diagnosing. So we just have to jump and do everything.
Yes. Well said, Dr. Pratheema. Any more questions? We are glad you have all of you have been asking questions and clarifying your doubts. Any more questions? We have a few more minutes left before we can wind up this session. So if there are no more questions, we can call it a day. Yes, all of you most welcome. You are glad that your doubts have been cleared. Thank you, Pratheema, for such a wonderful presentation, so crisp and clear, and also for clarifying all the doubts. And I'm glad the participants also took an active part in following the presentation, absorbing it, as well as raising the doubts. I'm very happy that this has been quite a good interactive session. So I think we can
so it has been a
session with this. Thank you, Pratheema, once again.